Good evening. My name is Dr. David Doman. Welcome to another edition of Housecall. What's new with the diagnosis and treatment of lung cancer? Find out right now. My guest this evening is Dr. James Zhu, a local oncologist and noted authority on lung cancer. Dr. Zhu, welcome to Housecall.
Well, thank you, Dr. Doman. It is really an honor to be here. And I'm very happy that I'm able to share with you some information about lung cancer diagnosis and treatment.
Excellent. Before we proceed with the discussion of the topic at hand, share with our viewers briefly your professional background.
Okay, so I'm a medical oncologist and hematologist. So I was educated at University of Minnesota. I received my medical doctorate degrees over there. Afterwards, I received my internal medicine training from Yale University in New Haven and Connecticut. And afterwards, I was trained as a hematology and medical oncologist at the Columbia University's Presbyterian Hospital in New York. And I've been practicing in this area for almost 4 years now.
And do you also, are you affiliated academically anywhere?
Actually, no. I'm very much like practice on my own at this point.
Okay. Right. So briefly, let's focus then on lung cancer.
Mm-hmm.
And what exactly is lung cancer? And tell us about the different categories.
Sure. So as you know, lung basically is an organ in your chest. The main function is trying to do the air exchange. In terms of lung cancer, there are really two main types of lung cancer. One is called non-small cell lung cancer. The other one is called small cell lung cancer. Non-small cell lung cancer are actually far more common than small cell lung cancer. Roughly, we have about 85% of the lung cancer are actually non-small cell lung cancer, and then 15% of them are actually small cell lung cancer. So the difference between small cell and the non-small cell lung cancer is based on how they look under the microscope when the pathology receives the tissue sample from the surgeon or the intervention radiologist. And based on the cell morphologies, then the pathologist is able to give us a diagnosis to say whether this is a non-small cell lung cancer or small cell lung cancer. Now, within the non-small cell lung cancer, there's also a few more categories over there. Very frequently, we see one type of non-small lung cancer is called adenocarcinoma. That consists of roughly about 40% of all the non-small cell lung cancer. And then 25% is called squamous cell lung cancer. And then another 25% is actually called a large cell lung cancer. The rest, about 5 to 10%, basically is a mix of all kinds of histology. So that's the categories of different types of lung cancers.
So what are some of the symptoms a patient could present with that would lead them to the attention of their primary care physician that might ultimately result in a diagnosis of lung cancer?
Yes, so this is actually an unfortunate part about for patients who have lung cancer. A lot of times people really do not have any symptoms. But then when the disease gets to the advanced stages, patients starting to have basically coughing out of blood, and then they start to feel difficulty breathing. And also, patient may have chest pain. So when they have so much symptoms, they will normally come to the primary care doctors, or they will actually go to the emergency room. So what is very unfortunate in this case is by the time the lung cancer was being diagnosed, they're already in a pretty advanced stage. So basically, currently we are actually in a process of trying to advocating early detection and or screening for lung cancers. But again, this hasn't been a case throughout the country. So if you have a hemoptysis, if you have a coughing out of blood, and difficulty breathing and also some chest pain, definitely you should think about lung cancer as a possible diagnosis.
So if a patient has any of these symptoms, how is it diagnosed? How is lung cancer diagnosed?
Right. Typically, as I said, if someone who has a coughing out of blood and someone who having difficulty with breathing, we typically will do a chest X-ray. And when we did a chest X-ray, we will see possibly some mass or some lymph nodes in the chest. And then that basically prompted the next stage diagnosis.
And what would be the next step if a chest X-ray is abnormal?
Right. If a chest X-ray is abnormal, frequently we will go ahead and do something called a CT scan of the chest.
Which is a different type of X-ray.
X-ray, exactly. So after the CT scan, what we do next is if the CT scan definitely show there are some abnormalities such as mass or such as lymph nodes over there, we frequently will speak to a pulmonologist, which is a lung doctor. We will also consult our colleagues who are thoracic surgeons, and these are the doctors who basically focus on the surgeries in the thorax, which is the chest. And these are basically the two main doctors we will consult. And nowadays, we also actually consult the interventional radiologists. And they are the doctors who actually specialize in looking at the CT scan, and also they are able to use needles and also less invasive procedures to get some tissues so we can establish a diagnosis.
Do you ever find that the patient's able to cough up material, sputum, and just make a diagnosis from that?
Well, that's actually a very, very interesting question. So currently, the tests we have really do not have the sensitivity. What I mean by sensitivity is a test, if they're able to pick up everything, then it's a highly sensitive test. So currently we don't have any of those kind of devices yet. But I think Dr. Ullman is really bringing up an excellent point, because it would be very nice somebody in the future will be able to develop a test just by coughing out of the sputum. We can actually detect some cancer cell, then we can make a diagnosis. I think this will really save the patient a lot of invasive procedures.
Are there any blood tests that are being researched to diagnose lung cancer?
Yes, that's again, we are really in the most forefront about discussion in lung cancer right now. So back in 2011, when I was still in training, I have a background in engineering, so I was very interested in developing different type of technology to see if we can detect the lung cancer, or maybe to characterize lung cancer in the most non-invasive or minimally invasive ways. So currently, actually, there's a lot of companies and also a lot of researchers in this country. We are trying to basically draw some blood from the patient, and we do so-called deep sequencing, which is a so-called next generation sequencing of the genomic profiling. We're trying to see.
By genomic profile, you mean the genetics?
That's right, the genetics of the cancers. And we're actually trying to see if we are able to, just by drawing the blood, and we can make a diagnosis, or potentially we can do certain tests to characterize the lung cancer. And actually, back in 2011, I was very fortunate, supported by our Cancer Society, which is the American Clinical Society of Oncologists. They actually awarded me a Young Investigator Award. And I was able to use those funds to do some research. And I believe at that time, I was the first person who was able to use the electrical voltage-based sequencing to find out different type of mutations for those cancer cells in the blood. So definitely, as you mentioned, this is really the way to go, because I think it will save patients a lot of invasive procedures. We can reduce a lot of risk for them. As you know, to have a lung cancer, it's very unfortunate. So as medical professionals like you and me, we basically need to do everything we can to make the patient feel comfortable when they are going through this a very high stressful period.
Let's go back and visit risk factors for lung cancer. Which patients are at particular risk for developing lung cancer?
Yeah. Okay. So I think most people know that lung cancer has a lot to do with the environmental exposures. So we all know smoking is a major risk factor to develop lung cancers. So by smoking, really across the broad spectrums over here, including regular cigarettes, cigars, and pipe smokings. Now, for the newer cigarettes, such as e-cigarettes, at this stage, we really do not have a strong evidence to see how big the risk it is of the smoking e-cigarettes associated with lung cancer. But we do know that there's a small substance called formaldehyde that was able to detect it from the vapor from e-cigarettes. So to answer your question with the first point is smoking definitely is a huge risk factor for lung cancer. And then another risk factor basically is radon gas. So radon gas basically is the gas for many household. It's basically the breakdown of the gas coming from the uranium in soil and the rocks. So what we recommend is everybody before you buy a house, make sure you do a radon check, so that you don't want to live in a house that has a lot of radons in it. And I think one thing I really like to point out is we're living in Montgomery County. Montgomery County is a very diverse population. And studies have shown that people from Southeast Asia and also from South Americans who drink a lot of water, the water from the natural resources, they may actually contain quite a bit of arsenic.
Really?
Yes. So those water with high arsenic actually is also considered as a risk factors for lung cancer as well. So I think in the future, people should really spend some time to find out, for people who had those kind of exposures, whether they be additional screening or preventative measures should be taken.
Are there any occupations that put you at risk for lung cancer?
Yes, certain occupation, we know that asbestos is one of the risk factors. It can also give you mesothelioma as well. It's a different type of cancer, but asbestos can do both lung cancer and mesothelioma. Another thing people do not realize is actually by smoking the coals, people who work in the coal mine settings, and also, for example, for the people who work in the gas stations, like diesel gas is also considered as a risk factor as well.
How interesting.
So we should we really should put in some focus on to reduce those risks of the occupational exposure.
Let's go on to discuss non-small cell cancer in particular.
Yeah.
If you diagnose it and it's localized to the just to the lung, we have about a minute left. Can you share with the viewers briefly what are some of the treatment options when it's localized?
Okay, well, if it's a localized cancer, our aim is really trying to cure the cancer. And typically, we will have the surgeon to see if this cancer is resectable. So at that time, thoracic surgeon will become a very important person in determining how to treat this kind of disease. And if the tumor is a little bit bigger, then the treatment modality frequently involves chemotherapy, radiation, and surgery together. So it's going to be a multidisciplinary team trying to treating this disease. But again, the goal is trying to cure a disease. Patient can live cancer-free.
Okay, so I'm going to ask you to hold a thought because we're going to pause for a moment.
Okay.
We're going to break briefly for a public service announcement. When we return, more with our guest tonight, Dr. James Hsu, focusing on cutting-edge information about lung cancer. We'll be right back.
Hey, Hard, what's this?
That's my resignation letter.
You're resigning.
Why? Because you're constantly ignoring me. You're half as active as you used to be, and you get stuff like this. You've been putting me under a lot of pressure lately. That's why I'm ready to quit.
I forgot. I'll do better. Please, don't quit on me.
Okay, but remember, it's not what you say, it's what you do.
Listen to your heart. Don't let it quit on you.
Let's go for a walk.
Uncontrolled high blood pressure could lead to a stroke, heart attack, or death. Get yours to a healthy range before it's too late.
We're back. Our guest tonight is Dr. James Hsu, a local oncologist, a cancer specialist, and authority on lung cancer. Dr. Hsu, when we paused for the break, we were discussing treatment options for different types of what's called non-small cell lung cancer.
Right.
And we, before the break, discussed when it's localized, when the patient is a possible candidate for an operation to just simply remove it. Let's discuss a more extreme situation. You diagnosed this lung cancer, and unfortunately, at the time of diagnosis, it has already spread elsewhere throughout the body. For that scenario, what is the patient's treatment options?
Yes, so as I briefly mentioned before, a lot of times when patients first present with the symptoms, they were already in a pretty advanced stage. So that's very unfortunate. However, we as oncologists, medical oncologists, we are trying to everything we can to alleviate the symptoms and also to slow the cancer's growth. So in this specific situation, when the cancer has already spread and has been in an advanced stage, we typically have to give systemic therapy. So by systemic therapy, what I mean is giving the patient certain medication so that it will be disseminated across the entire circulation systems, so that it will go to wherever the cancer goes and trying to attack the cancers over there. So currently, we have three types of systemic therapy in lung cancer. I would say about 10 years ago, maybe even 15 years ago, the treatment options for lung cancer is always chemotherapy. As you know, this is the thing that has been there for many years. But very fortunately, I think after 2003, all of a sudden, there becomes a target therapies. And what target therapy means is that they target specific gene mutations, genetic mutation in lung cancer. And that works pretty well. And very, very recently, which is about 1 or 2 years ago, we actually have a new treatment modality called immunotherapy. Again, this is also a systemic therapy. It's the medication we give by intravenously to the patient, and it will go over the patient's entire body and try to look for where cancer is. So what immunotherapy is, this specific immunotherapy is trying to stimulate the patient's immune system so that they can start to look for the cancer and try to fight those cancer. So this is very new, and it just come to the become one of the treatment options about 1 year and 2 years ago.
So this basically stimulates one's own immune system to attack the cancer cells as foreign invaders.
That's correct, yes.
And when you give that kind of immune therapy, how many IV infusions do you need to give?
Yes, so basically there are two types of immunotherapy that are currently in the market. One is called nivolumab. The other one is called pembrolizumab. So typically what we do is patient will come to the office, we give the IV infusion. That actually lasts very short. It probably just an hour or 2 hours. And then patient can come back in 2 or 3 weeks. So it's really actually not very inconvenient for the patient. You will just come probably once every 2 to 3 weeks, and you will receive those therapies by IV intravenous injections.
Now, I'm sure that our viewers realize that when you give old-fashioned chemotherapy, they've heard all the stories about the side effects.
Exactly.
The nausea, the vomiting, the weight loss, the hair loss, etc.
Right.
How does that compare with immunotherapy in terms of side effects? What kind of side effects do you get with this new cutting-edge treatment?
Yes, this is actually also a great question. This is actually a double-edged sword. So typically in most of the patients, if they tolerate this procedure well, the side effect is actually very minimum. People will have some nausea, vomiting, people will feel some fatigue, but the severity as compared to the traditional chemotherapy is far less. However, when we say that, this is not a golden bullet at this point. For some patients, for example, some of the patients who already have some autoimmune disease, then when you give this...
And by autoimmune disease, you mean?
Oh, that's right. That's right. Thank you for pointing this one out. So autoimmune disease is basically somebody who, for example, one of the examples would be lupus. Someone who already, basically this person's, his or her own immune system was already acting up. It was already trying to attack the body itself. So this is what we call autoimmune disease. Basically, it's your own immune system that's trying to attack your own body. And that's actually in the negative ways. Yes. It's causing a negative health effect on you. So for those patients who already had autoimmune disease, then we really should be very careful in giving this medication. Because as I just mentioned, the concept is actually trying to stimulate your body's immune system to fight the cancer. So by stimulating your immune system to fight the cancer, at the same time, it's possible that they can stimulate your body's immune system to fight yourself. So we typically, when patients who had autoimmune disease, we typically have to do additional assessment before we feel confident enough to give this kind of therapy. So now, if people have immune reactions, typically we were looking at a few organs. One is the skin. They will have a lot of rashes. Basically, this is the immune system was attacking the rashes, attacking the skins. They can also have a colitis. As you know, you are a gastroenterologist. You know that when we give the immunotherapy, you have a lot of diarrhea, and those antibodies is actually attacking your stomach guts. Yes. So that would be another side effect. Another side effect is actually what we call endocrinopathy. By endocrinopathy, basically, is your body have a system that was trying to releasing different type of hormones, including insulin, growth hormones. So sometimes this autoimmune system, your immune system is starting to attack your body's own endocrine system, sure. And you actually may develop a diabetes as well from that. So we really have to be very careful when we give this medication. But this is relatively not as frequent as the other minor side effect.
Now, given this emerging role for immunotherapy, mm-hmm. is this viewed in the cancer oncology community as something that is given after chemotherapy or mm-hmm. concurrent with chemotherapy or instead of chemotherapy? Right.
So this is actually a big question. And actually, this is a really, I would say, $1 billion question. Yeah. So we really do not have a very good marker at this point. People have been trying to do some diagnosis tools. They're trying to do some diagnosis on the cancer tissue to see if those diagnoses will direct a physician regarding whether to give chemotherapy first or immunotherapy first. But so far, we don't really have a very definitive answer yet. But we do know certain markers. What I mean by markers is certain diagnostic features of the cancer tissues will give you a higher probability to respond to this therapy. So, as you know, when we're treating cancer patients, we always want to give the patient the best odds. When all the criteria are being met, meaning that after we profile the patient, profile the tissues, we may actually recommend to giving the immunotherapy before the chemotherapy. But this is still under the study right now. So typically at this point, we will still recommend to give the chemotherapy up in front. If the chemotherapy does not work, then one can try immunotherapy.
So let's discuss then what has been the preliminary mm-hmm. Observation about immunotherapy since it's only been mm-hmm. popular in the last year or two.
Right.
What are you seeing in terms of response rates mm-hmm. Compared to when it was only chemotherapy?
That's right. So this is actually a very, very good question because I think we really have to go into the very depth about this discussion. So if I have a patient who has lung cancer and randomly find this patient, and the odds of the patient response to immunotherapy actually is a little bit lower than the odds to responding to the chemotherapy. So one of the example would be like this. Immunotherapy can be a certain target therapy, but chemotherapy is more like a shotgun type mm-hmm. of therapy. As you can see, if you have a shotgun, you have a wide range of target. Sure. So when you have this type of approach, typically the odds about having a response is a little bit higher in chemotherapy. Mm-hmm. That's the reason at this stage, we will still say, perhaps we will still go ahead and do the chemo first. And then until we have a very reliable biomarkers, we let the patient try the chemotherapy. If chemotherapy does not work, then we switch them to immunotherapy.
And have you seen people respond who failed chemo who did respond to immunotherapy?
Yes, we did actually. Yeah. And actually, some patient was doing pretty well because, as I mentioned before, I would have to say these are the lucky one out of the unlucky events. They actually had a pretty little adverse toxicities, but they are able to hold on to the response for quite a long time. So these are really the fortunate the patient was able to derive a benefit from this therapy.
I know it's still early in terms of your using it. It's only been a couple years.
That's right.
But in terms of the clinical trials that preceded it, which presumably have a longer timeline of follow-up, mm-hmm. has anyone been declared a cure after immunotherapy?
So actually, I think this is actually a very controversial topic. For example, let's just shift a little bit away from lung cancer, and then we go back. So, for example, President Carter, he was treated with immunotherapy, and he has brain metastasis. So at this point, there's no, basically there's no cancer in his brain. So in one sense, you can say, oh, maybe Mr. Carter at this point is cancer-free. But in order for us to say someone is cured of cancer, we say you have to be cancer-free for at least 5 years. So for lung cancer at this point, as far as I know, I have seen patients had a continuous response for many years, but I haven't seen a patient was disease-free for more than 5 years.
We just haven't had the long enough timeline.
That's right, yeah.
We'll have to invite you back in a few years.
But definitely be happy to.
Yeah. Let's shift gears in the few minutes we have left then to discuss targeted therapy. When do you decide somebody is not responding to chemo and immunotherapy, and then it's time to visit this new topic, targeted therapy? First of all, define for our viewers what is targeted therapy.
Sure. I think, when we talk about target therapy, the first things we should talk about is called genetics. Lung cancer typically is I would have to say, it is a genetic disease. It appears to me that this is because of the environmental toxin exposure causing the genetic mutations. And then those lung cancers becomes unchecked and they start to develop. So we have discussed several genetic mutations that is associated with lung cancer. So speaking of the target therapy, this thing really started in 2003. That was actually a very interesting story. There was a woman who lives in Boston, and she has tried everything that's possible for her lung, for advanced lung cancer. Then she went to Massachusetts General Hospital, and then they gave her an experimental drug. At the time, nobody believed these drugs would work. And that drug has been tried in many other cancers. It does not work. However, when we give this pill to this woman, and she had a miraculous response, and the news was going to the newspaper, the Boston Globe, and immediately this attracted a lot of attentions from the scientists as well as the clinicians. So, to go back to target therapy.
I should tell you, by the way, we have 30 seconds left.
Okay, so this is basically trying to find a genetic mutation and find a molecule that's specific to inhibiting tumors. We typically would do a genetic profiling first to find if a patient have this kind of mutation. If they do, we typically give the target therapy first. If they do not, then we go to the chemotherapy and immunotherapy. And
you've had some preliminary success with this new generation targeted therapy.
Yes, we do actually.
Well, unfortunately, we have so much to cover, but we've run out of time. Dr. Hsu, thank you for joining us on Housecall.
All right, thank you. Yeah.
Mike, thanks this evening to Dr. James Hsu for a very informative overview on cutting-edge information dealing with lung cancer. My thanks to my terrific team here at the studio, but most important, thanks to you, the viewer, for watching Housecall week after week. We're now well into our 3rd year. Let us know how we're doing. You can reach me at my practice website, montgomerygastro.com. We're very open to suggested topics for future programming. As for my next show, my special guest will be Dr. Lynn Diggs, president of the Montgomery County Medical Society. And Dr. Diggs will be discussing Montgomery County healthcare issues. It's going to be a terrific show. See you then next time for another edition of Housecall. Good evening.
Everybody has a dream. Mine was to see the ocean. And with a little help,